Wes.
Yeah, you're in the chair. Look, first of all, can I just begin by thanking the committee for all of the contributions you've made to the development of the 10-year plan through your inquiries and evidence, particularly into the first 1,000 days, community mental health services and healthy ageing. And we're looking forward to working with the committee in the coming months and years, both to hold us to account for the delivery of the 10-year plan, because I think it's fair to say that the reception to the plan has been extremely positive. The question everyone asks is, are you going to deliver? Which, given people's trust in politics and politicians, is not a surprising question, but it's one we definitely need to answer in the affirmative. I'm really proud of the way we've built the 10-year plan, not just taking on board the views of the committee, but having what I think is the biggest national conversation since the NHS was founded about its future. We received 250,000 responses through the Change NHS website. There were over 600 in-person events right across the country. They involved the people working in the NHS as well as the people who use the NHS. I'd just like to say a big thank you to all of our colleagues across the House who hosted 50 events with constituents across the country. And what we found, of course, is that people are extremely anxious about the NHS and its future. They feel that sense of jeopardy. And there isn't a single person using the NHS or working in the NHS who would say the National Health Service as it is today needs to stay exactly the same and exactly where it is. Everyone can see the scale of the challenge, and people want to see the NHS fulfilling its founding promise, which is to be there for everyone when they need it, and to do so in a way that defends the equitable principles at the founding of the NHS, the principle that healthcare should be based on need and not the ability to pay. We know the challenges are going to get harder, particularly with our growing ageing society and rising levels of chronic disease. And I was struck through the public engagement at the extent to which the general public wanted to talk about public health and prevention, not simply the service itself, which is encouraging because we're going to need their help to create a fairer and healthier nation. We inherited record waiting lists, the lowest ever levels of patient satisfaction, staff burned out and walking away. And all of those things, I think, fuel that sense of jeopardy that people feel about the NHS's future. But there are also grounds for optimism. This country is one of the world leaders in life sciences and medical technology. We need to make sure that we are not just benefiting from that revolution, but actively driving it and making sure that those innovations are being adopted and rolled out consistently across the NHS. We know that thanks to the decisions taken by the Chancellor, the NHS has been the relative winner at the budget and spending review. So this is a funded plan for the next few years, and that sense of medium-term certainty will help the system to deliver and design their services in a better way. I think the thing that is fundamentally different is about how we imagine the NHS working in the future. At the moment, the NHS is a very centralised, top-down state bureaucracy. The NHS of the future needs to be one where power is devolved, where there is far more freedom to the front line. We've got some brilliant people working at the front line. We've got some brilliant leadership capability throughout the NHS. We need to set them free to do the job as well as holding them to account. And finally, the most important revolution of all, as far as I'm concerned, is the revolution needed in patient power. When Nye Bevan established the NHS in 1948, he said he wanted it to hold a megaphone up to the mouth of every patient. But the NHS that we see today is a far cry from that vision. Patient voices are too often unheard, their complaints dismissed or discouraged, and the NHS needs to move with the times. Patients need to have far more ease, convenience, choice and control over their healthcare, and that's at the centre of the plan.
Fantastic. So that goes very nicely into the first question that I want to ask. You've talked about the 3 shifts at the core of the plan and the long-standing ambitions, but Wes, We have seen these in multiple NHS strategies, for at least the last 30 years. So the question I'd like to ask you is, why do you feel this plan will succeed when so many others have failed?
Yeah, it's a very good question. You're right, the 3 shifts were not in themselves radical new ideas, but delivering them really would be. Why now and not before? I think there are a few things in our favour. The first is the sense of jeopardy that the public feel about the future of the NHS is felt right throughout the service. We've prosecuted an argument in opposition and now in government that it's change or bust, reform or die, and I think that there is overwhelming consensus in that direction. People in the NHS want to see it change, they know it needs to change, and they are up for it. Secondly, how we do the change is as important as what the change is, because if you think, thinking about some of the things contained in the plan, whether they're new models of service delivery, new commissioning arrangements, new innovation in terms of medical science and technology, we will only succeed in delivering this plan if we're doing change with people rather than to them. And that's why, in terms of how we've approached some of the challenges as a government so far and how we will deliver this plan, we will make sure that the implementation is designed with as well as delivered with people throughout the system. And already, Jim may want to say more about this, we've had people banging down the door since the plan was launched saying, we're really interested in this new model of neighbourhood health, we want to go first. We're really interested in the reinvigorated foundation trust model. How can we have a piece of that action? These integrated health organisations, how can I be part of it? And that's exciting for me because we can
Wes, do you want
get
me
those
to
people
bring Jim in now so that he can just finish that off?
Yeah, so just
Jim,
to add to that, we had a chief execs gathering on Thursday where we've created some groups to develop the next parts of the plan on neighbourhood health, integrated health organisations, the medium-term planning and financial rules. So a handful of bits of work, the NHS app, etc. Really strong engagement. So the last count, this is still moving, are about 120 volunteers for chief execs and their organisations to participate and want to get out in front. I've actually just left a call with a colleague ahead of a session later on where Secretary of State's pointed out there's this real tension of real ambition and desire to get out and start delivering this stuff at pace, a will to work in a new way, but also wanting more detail. And we just got to get that balance right and hold our nerve on, we'll develop the detail with colleagues in the service because that'll work better and it'll give us a better chance of success. So that's really what the next few weeks are about.
So what do you feel has been, from the previous attempts we've tried at reforming, what do you feel we've learnt from those previous attempts that we can bring in to this particular reform?
So I think the worst thing we could do is to take the plan and the end state that we're aiming towards and try and impose it all in one go now. I think the lesson of the Lansley reforms is that a big top-down reorganisation imposed on the system doesn't work. And when you follow through the logic of some of what Andrew Lansley was saying, I could see the method in his madness, but the execution was really poorly done, and some of the ideas at the outset were ill-conceived. And I know we've taken a bit of flack for the fact that we did a big engagement exercise to build the plan, and we will take some flack for the fact we're working with people on designing implementation, but that is a far, far better approach than the alternatives that we've seen. And I think the other thing to that point as well, with some of the models we're going to roll out, particularly think about primary care, the principle is you set people free to lead the path to the future, to show us how the new model will work, to be the early adopters and the pioneers, and in doing so inspire other people to follow. And doing that in a way that doesn't go in like a bull in a china shop and say to a primary care network, for example, although you're working really well and you're driving innovation and you can demonstrate year-on-year improvements. We, the government in Whitehall, have decided that we don't like your model, we're going for a different one, and we're just going to go in, like a bull in a china shop through your thing that's working. So we're not interested in going in and bulldozing through things that are working in pursuit of the thing that we think will be the future. Far better to let people themselves opt to be the pioneers, to show how it will work in practice, and then inspire other people to follow.
Really good place to stop there. So my next question is relating to dentistry. And last week we had Minister Kinnock, who told the committee funding for dentistry was likely to be in the region of the current financial envelope. Given the ambitions and the plans you have to reform NHS dentistry, why have you not committed to increasing the dentistry funding to pre-pandemic levels? Will you be reconsidering your decision?
Well, so a few things in response to that. The first thing we could do is make sure that we are making the most of the money that's already going in. And in opposition, we complained a lot about dentistry underspends. And one of the ways in which we'll be looking to address that, obviously some of the things we're already doing, the 700,000 urgent appointments that are being rolled out, but we know that fundamental contract reform is needed. There is a tension, there is a constant tension for me between the level of ambition we have as a government, the level of demand put on us by the Parliament and the public, and the choices and trade-offs that we face when trying to deal with an NHS that has such a breadth and depth of challenges. So,
Wes, let me stop you there, because you could talk for another 5 minutes and I haven't got 5 minutes. Will you be considering
so I said I was
that
scared
decision?
of you during this meeting. Yeah,
Shut up, Wes. Will you be reconsidering it?
Look, it is something we are constantly put under pressure on from Parliament and the public. We will do as much as we can, as fast as we can on NHS dentistry.
Absolutely awesome. And my final question is around palliative care. So, palliative care does not feature significantly in the 10-year plan. What I've noticed is it's been mentioned, I think, about 4 times with all the experts that have trolled through it. And also in the index, you mentioned something about palliative care, but it wasn't actually, nothing was said on palliative care. With all the issues we've now got to address inequalities, we're looking at palliative care through the 10-year plan, also through the context of the terminally ill. How are you planning to address palliative care going forward? Because that is becoming, I'm going to use the word from last week, a burning platform.
Yeah, so palliative care does feature, particularly in the context of neighbourhood health services, and I feel very strongly, and having seen palliative care in a range of settings and frankly a range of quality of provision, the principle we want to see in palliative care is the same as the rest of the NHS, which is giving people real choice over the care they receive, when they receive it and where they receive it. And for some people that'll be in hospices, for some people that'll be the comfort of their own home. Wherever possible, we'd prefer it to be the latter, but that won't be right for everyone. We've obviously taken some steps already in our first year with £100 million for hospices through capital investment, which has been used to good effect to either expand or modernise estates, or often buy the kit that's necessary to provide good hospice at home care. And the £26 million Children Hospice Grant, I know, has made a real difference as well.
Whereas if we talk to the sector, what they're saying is they've used over 70 million of that 100 million to do the national insurance payments. So it's only left them with, I think, about 24 million. This is what they're telling me. And what they've said is this is going to become a burning platform. Is running out, and some of the organisations are actually saying now that they will be closed in the next 6 months to a year if they don't get the support they need.
I'd say, I've never been comfortable with the extent to which hospices are reliant on the generosity of the public through donations to fund something that I think in today's day and age is an integral part of the health and social care system. What I can't do with the scale of the challenge that we currently stare into and the pressures on the public finances commit to moving us as far down that route to state funding as I would like. So in the meantime, I think, certainly we will continue to do everything we can through state investment. I indicated at a reception recently for Havens House Children's Hospices, which serves my constituency, and we had Hospice UK and Together for Short Lives and other amazing charities there. I think it's worth us looking at what we can do with the sector to see if we can leverage in more support through things like match funding and other schemes to try and get more investment into the sector. So we're open to those sorts of conversations.
And I know they appreciate that. So my last point would be, when will you start considering working with the sector to look at a new strategy, read the way forward? Because that was talked about last year, and the sector really do want to work with the government, like many others, to just get to that point where they feel as if they're being heard and being inclusive. So how long will we be looking at the government really starting to work with this sector? And it just needs to be a few words.
Yeah, and we do engage with the sector. I will certainly pick up your line of inquiry with them. But the second thing, I know there's been an initiative for a commission on end-of-life care, which has been established. It's independent of government. We'll be following their work carefully and looking at what they recommend as well.
Thank you, Wes. Can I hand you straight over to my second committee member, and it's Joe Robinson.
Afternoon, Secretary of State. I'm going to stick with some of the bigger themes that we dealt with at the beginning. In fact, you've already touched on some of them. And I'm going to quote, "Investment has to be accompanied by reform. The NHS has to be redesigned around the needs of the patient. Local hospitals cannot be run from Whitehall. There will be a new relationship between the department and the NHS, etc." Presumably that's an underpinning principle that leads to things like a decision to abolish NHS England.
Yeah, that's absolutely right. And what we're trying to do is a few things. One is to shrink the size of the centre, make its focus more strategic and holding the system to account on outcomes, and devolving as much power, resource and responsibility closer to the front line and at the front line as we possibly can. We also want to make sure that our financial flows and incentives are aligned with our public policy objectives. So, because if there's one thing I've learned about this system in the last few years that I've been in this portfolio, is that money talks. And if you get your incentives aligned or indeed misaligned, you either get the desired outcomes or the completely unintended outcomes. And that's why working with the system on the design of those is going to be really important. We also want to make sure through the technology and innovation side that we've got a big focus on productivity, because it's one of the big challenges, not just for the NHS, but given the size of the NHS, it's a challenge for the British economy.
Just try another one.
The NHS is more as productive as possible.
Yeah, can I try another one, which I hope you'll agree is a theme, a different theme, but nevertheless a theme. So a quote, "The NHS has been too slow to change in its ways of working to meet modern patient expectations for fast, convenient, 24-hour personalised care. Changes in primary care will help ease the pressure on hospitals so that they can concentrate on providing specialist care." I mean, that, presumably in a nutshell, is the shift from hospital to community.
Completely agree.
Yeah. So my concern is that absolutely none of this is new. Well-meaning, well-intentioned, but none of it new, because the two quotes I've just given you are actually lifted directly from Alan Milburn's NHS plan in the year 2000.
And that plan delivered the shortest waiting times and the highest patient satisfaction in history, so it sounds like we're on the right track. But there's lots of stuff in the plan.
Is this a back to the future? Are you Doc Brown taking us back to the year 2000 to sort out the NHS?
No, I've not gone that grey in this job yet. But I think the themes are, as I think we said in response to the Chair's questioning, like the shifts themselves are not new ideas. delivering them in practice in this NHS really would be. And there are lots of things contained within the plan that are new models, new ways of working, a new approach to innovation, adoption and rollout. So there's plenty of things in there on the prevention side that are novel and innovative, as well as things that are well evidenced and need to be rolled out more consistently.
Perhaps you can help. What's the difference between community diagnostic centres, multidisciplinary GP surgeries, DARSI centres, and now, your word for it, neighbourhood hubs? I mean, these are things that have run from the year 2000, 2008, 2012, and now your plan. They sound like the same thing, just with different names. Your name is neighbourhood hubs. Perhaps you can start by telling us how that's different from community diagnostic centres or DARSI centres from 2008.
Well, DARSI centres, or polyclinics as they were known, were effectively strangled at birth. There are still a few around, but it was a source of huge controversy at the time for something that I think, as an approach, I think people agree doing neighbourhood health and population health at scale is a good thing to do, and that was certainly borne out through the consultation